Hello, everyone. Welcome to today's live broadcast, Oscillations, Deep Brain Stimulation, and the Functional Network in Gilles de la Tourette Syndrome, presented by Rowshanak Hashemiyoon, PhD. I'm Julie Simmeroff of LabRoots, and I will be your moderator for today's event. LabRoots is the leading scientific social networking site, and we are extremely proud to bring you this interactive web seminar. For more information, visit us at labroots.com. Here's how this presentation will work today. We want to hear from you. Questions, comments, and even answers can be submitted via the green Q&A button at the lower left of your screen. We'll try to get to everyone, but if not, we will make sure to follow up with you by email. You can also enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you cannot hear or see this presentation properly, let us know by clicking on the support button at the top right or the Q&A button in the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. I would now like to introduce today's speaker, Dr. Rowshanak Hashemiyoon. Dr. Hashemiyoon is the head of the Human Brain and Behavior Laboratory in the Department of Stereotactic and Functional Neurosurgery at the University Hospital of Cologne in Germany. Her work unites scientific research and clinical care. It focuses on identifying the altered network dynamics underlying the dysfunctional brain states of neuropsychiatric and neurologic disorders, as well as fosters the development of novel treatments which alleviate the symptoms of these disorders. Please join me in welcoming Dr. Hashemiyoon. I will now turn the presentation over to her.
Hello, thank you, Julie, for that very kind introduction. And thank you to LabRoots for inviting me to give a presentation today on oscillations, deep brain stimulation, and the functional network in Gilles de la Tourette syndrome. My talk today will focus on identifying the network dynamics giving rise to Gilles de la Tourette syndrome. And in particular, I want to explore with you the expression of oscillations and their aberration in the dysfunctional circuitry of the cortical-basal ganglia thalamo cortical loop, and how that's correlated with Gilles de la Tourette or GTS symptomatology. Finally, we'll see how the advance of deep brain stimulation technology can serve not only to remedy, but to assess the pathophysiology of GTS. So, we need to define Gilles de la Tourette syndrome, and unfortunately it doesn't have a definitive diagnostic test, so it's classified based on the observation of symptoms. The symptoms or criteria necessary for diagnosis are a childhood onset. It's usually diagnosed between the ages of 4 and 7 years old. Multiple motor tics, and at least one phonic tic, and I use the term phonic intentionally because some of the tics do not engage the vocal cords. And also it must be persistent for at least 1 year and not attributable to drugs or other medical causes. So we're talking a lot about tics in the clinical diagnosis of Tourette's, and because of that it's important to define them properly. Tics are sudden, purposeless, and repetitive, and can be either motor or phonic. So some examples of motor tics include blinking, shoulder shrugging, grimacing, jumping, obscene gestures, hitting, and self-injurious behavior. And examples of phonic tics are throat clearing, whistling, coprolalia, barking, sniffing, that's a phonic, not vocal one, and yelping. So now that you've seen a descriptive definition of GTS, I want to show you the human face of it. The following clip is a courtesy of Stage 29 Productions, The Doctors. It is archival footage from 2010. Can we have the video, please?
I remember just trying to keep my mouth shut or keep my legs still, and I couldn't.
What's the matter? My chest, my back, my neck, my head, my whole body practically.
But I started to get scared.
We took Ty into a child psychiatrist, and he said, "You don't need me, you need a neurologist."
I was officially diagnosed with Tourette after I just turned 10 years old.
The tics snowballed into painful, self-abusive tics very fast.
It really started with hitting myself in the stomach and the chest.
He would snap his head forward so violently that he ended up with a bruise on his chest bone and a bruise under his chin.
Oh, no, take it off.
Well, just a minute, I just want to show him the bruise there.
Oh.
Tip your chin up to the side. What's that bruise from?
It's my chest, it's my chin, like this. Ow. That hurts.
When he stood up, he would throw himself on the floor.
I spent countless hours just curled up in a ball crying because I didn't know what to do.
He was trapped in this no matter where he was.
I'm never gonna get better.
Going to school drove me out of my mind. I didn't know how to cope with it.
Come on, sweetheart.
Mom, I want to stay home.
Well, we need to go. Come get your backpack.
There are big gaps in his education.
I'm feeling terrible. I feel like I'm gonna explode.
I eventually started chewing through my cheek, and it swelled up really big. I wore a mouth guard or just stuck a washcloth, wadded as much as I could into my mouth. I've dug my fingers into my eyes. Fun became a word that was kind of just imaginary.
I just hurt so bad that my son was home on the couch in protective gear, missing life.
That's left scars. I mean, I had suicidal thoughts.
No matter what we tried, there just wasn't anything out there that would fix it.
I felt very hopeless and without anything to turn to.
So, as you can see, Tourette's can be extremely debilitating. Unfortunately, it's often associated with coprolalia, which actually only affects a small percentage of the patient population, and this is when people blurt out obscenities, etc. But it can be quite physically debilitating and very painful for the patient and those around them. Now, Tourette's has a range of symptoms, which you've seen, and they can be expressed differently at different times. And we saw the changes in symptom type, severity, and location in the video. But tics can also vary in their frequency, number, and complexity. And this waxing and waning of symptoms is non-trivial, as the constant changes in tic expression can confound the therapeutic strategies. The clinical observation of waxing and waning of symptoms over time can also be expressed computationally as a periodic higher order combination of tic bouts, and that's what we see here. The temporal occurrence of tics can be statistically characterized as fractal. Now, the expression of some of the symptoms of GTS might also be attributed to its comorbidities, which can occur at up to 80% with such disorders as ADHD and OCD. But there are also many limbic disorders associated with Tourette's, such as anxiety, rage, and depression. So it's important to remember that Tourette's is a disorder possessing both motor and limbic components. Oops. So, sorry, I seem to be missing a slide here. There we go. The cortical-basal ganglia cortical loop that we discussed is made up of multiple parallel circuits which are named for their cortical areas of origin. Here you can see three of them: the motor circuit, the associative circuit, and the limbic circuit. And these are relevant for GTS and for other neuropsychiatric disorders. Now, these pathways communicate information relevant to the functions as they're labeled. And the information is somatotopically transmitted, with generally the motor circuits composing the dorsolateral stream, the dorsolateral division, and the limbic circuit composing the ventral medial stream. So the projections from the frontal cortex follow this topographic organization through the subcortex, and each circuit is devoted to its discrete behavioral function. That means that the dorsal and the ventral streams are relaying very different information, although there are some regions in which the information flows between the segregated pathways, and that allows for new behaviors from the integration of information from the different parallel pathways. So the take-home message that you need to know is that the cortical-basal ganglion is a rather large network, besides being a mouthful, and it's composed of multiple circuits, the three that we see here, for example, and there are more, and it's well positioned to integrate motor, cognitive, and affective motor processes. So, there's a very nice visualization modified here from Langet et al., where you can better see the structures of the basal ganglia that are the core of the cortical-basal ganglion thalamocortical loop. And you can see that together here with the thalamus. This figure gives a good feel for the intimate physical arrangement of all of these. So the basal ganglia here, you can see up on the top left, are composed of the striatum, which is the caudate and putamen. That's the red and the blue. The globus pallidus, just under and next to it, in the externus in like a purple, and the internus in green. And then you see a very large thalamus, and underneath that is the subthalamic nucleus and the substantia nigra. The basal ganglia receive massive projections from nearly all the functional subdivisions of the cortex, and then through its efferents to the thalamus connects back to the better part of the entire neocortex. Now, I'm going to show you a video to give you a better feel for the essential role of the basal ganglia and the larger network and their central position in the brain. In this video, you'll nicely be able to see the spatial relationship of the basal ganglia and the larger network. I want you to notice the size and position of the network, because you'll see except for the turquoise blue, all the other structures you'll see will be visualized in different colors, and that will comprise the basal ganglia, which sits at the base of the forebrain and spans the midbrain together with the thalamus. It fills up the majority of the diencephalon, so it really takes up a very central area in the brain. So if I could have the video, please. So I hope that gave you a pretty good feel for what the size and position of the circuit really is in the brain, and how important it is, how essential it is to function. The basal ganglia were originally thought to be mainly involved in voluntary movement and movement coordination, but are now known to be active in learning, memory, and habit formation. So let me see if I can. There we go. Sorry about that. So here I want you to see a schematic of the network. So you can clearly see here that the parts of the CBGTC, cortical-basal ganglion thalamocortical loop, are highly interconnected in these structures. And what should be noted here is that the striatum and the STN, or subthalamic nucleus, are the input stations of the basal ganglia, and the GPI, globus pallidus internus, and SNR, substantia nigra pars reticuli, are the only output stations, and that the output of the basal ganglia is predominantly going to the thalamus. The way that the information gets from the globus pallidus, or the GPI SNR, from the striatum is described in two pathways known as the direct and the indirect pathway. Now, in this slide here, you see the direct pathway is highlighted in beige, and you'll see that the striatum receives massive inputs from the cortex, and it sends its efferents to the rest of the basal ganglia through either, as I said, the direct or indirect pathway. And here in the direct pathway, you can see that it goes straight from the cortex to the striatum to the GPI, and then over to the and then over to the thalamus, back up to the cortex. Here in the indirect pathway, you have a polysynaptic connection between the striatum and the GPI-SNR. And here in the indirect pathway, D2 dopamine receptors are expressed, whereas in the, let's see if I can get it back, in the direct pathway, you have a D1 receptor-mediated pathway in this monosynaptic connection from the striatum to the GPI-SNR. Now, TIC expression is thought to be the result of excessive activation of the direct versus the indirect pathway, which explains the success of D2 antagonists in relieving tics. There is also a third major pathway known as the hyperdirect pathway, which you see here highlighted in purple. And this bypasses the information from the cortex bypasses the striatum and allows the cortex to powerfully excite the GPI-SNR with fast conduction times and a widespread divergent activation. Together these pathways are suggested to act to select a desired motor program and inhibit undesired motor actions in what is known as this center surround model for action selection. So this model incorporates the complex range of activation patterns mediating basal ganglia function that arise from both varying timescales as well as differential anatomical connections. So how does that work? First, you can see that the cortex is powerfully transmitting information through the fast-conducting hyperdirect pathway, which works on a faster timescale, as we mentioned, than the direct pathway. And it also projects more diffusely than direct pathway, which means it's providing a general excitation over a large population of the GPI output neurons or the surround neurons, which are either competing or unwanted motor actions, since they're not the selected motor program. So the code for the desired motor program is then transmitted serially through the direct pathway, which is a little more slow and but more focused to the center neurons of the GPI. Then these disinhibit the thalamus and release the desired motor program. So you can see the spike activity of the neurons in each of these pathways on the left and the right of the, I'm sorry, I don't have a pointer, of the slide. So the final part of this tripartite behavior is the late excitation of the GPI neurons from the signal transmission of the through the indirect pathway. And it's this mechanism, the whole thing, that's hypothesized to effectuate precision initiation and termination of the selected motor programs. And in this way, we inhibit unwanted or competing ones. So the integration so it's important to realize that the integration of information between these circuits is how you can get something from the, in the cortical-basal ganglia cortical loop, from these circuits that's suggested to be essential for action selection and also the conversion of goal-directed behaviors to automated behaviors. So it's really the balance of the normal balance in the basal ganglia function that gives us proper coordination. So the balance between the direct and indirect pathways, and a disturbance in that balance or that coordination could lead to the changes that result in the hypo or hyperkinetic disorders that that we observe, including Tourette syndrome. So this is an example of a hyperkinetic dysfunction that's expressed in the unwanted tic behaviors that we observe in GTS. And here you have excessive dopamine inhibiting the indirect pathway, leaving the direct pathway unopposed, and releasing these spontaneous and uncontrolled movements. Now, proper coordinated activity is from the relevant network leads to the observed behavior in the macroscopic scale via faithful transmission of information. But what mode of communication might networks use to accomplish this? Well, oscillations. So oscillations are suggested to be the means by which different brain areas communicate with each other. And this cooperativity between neurons can be translated into the physiological spatiotemporal pattern of activity observed in oscillations. So here you can see a simulation of an oscillation. This is a 10 Hertz frequency. The upper panel shows the spiking of individual neurons, with each dot representing an individual action potential within the population. And the lower panel is the local field potential that reflects their summed activity. Frequency, the frequency that we observe when we say things like a 10 Hertz oscillation, etc. This results from the summed rhythm of the network. So it's important to understand that an oscillation results not just from, it results from the coordinated activity from an ensemble of neurons. It's not just one neuron firing during each cycle, but it's the ensemble of neurons that synchronize their fluctuations within an acceptable boundary range. So it's very important to keep a temporal order here. So the structure and the correlation of their activity. And the amplitude that you see in the local field potential is a result of how many neurons are participating in producing the oscillation. So oscillations are thought to be crucial to neuronal communication. They're ubiquitous in the brain, and they're found correlated with all kinds of normal brain function, like cognition, vision, sensation, perceptual input, motor output, speech, and even thought. But what happens when good synchrony goes bad? You get impaired communication, of course. And this abnormal synchronization is what's implicated in brain disorders. So it's kind of like can you hear me now? When you're on the phone with someone and they're talking really loudly, the information comes in distorted to you because there's too much noise, it's too much synchrony in the information that's coming in. You can think of it that way. So this is what I think of as a hypersynchrony. And when someone's talking very quietly on the phone, you don't hear them very well, and you're like, can you speak up a little, as opposed to before, and you're like, can you bring it down a little? And that's analogous to hyposynchrony. So I want you to think of it in those terms if that helps. So in the case of good synchrony, you have good phase relations. And the mutual interaction occurs in phase here, as you can see, where the marked black lines are. And good mutual interactions which occur in phase allow for the most faithful transmission of information. But what happens, again, as we said, when good synchrony goes bad? In the case of bad synchrony, you can have something like hypersynchronization. And this is the kind of thing that's been correlated with several disorders, including Parkinson's, tinnitus, and neurogenic pain. And what you can see if you look at the red arrow, that's moving, showing time moving to the right, and each of those dots, again, are an action potential of a neuron. And you can see that as time progresses, when this good phase relation continues, you get an increase in mutual information, as you can see underneath in green. And as you get an increase in mutual information, because the phase relations are together for even longer and longer and longer, you get a decrease in the information coding capacity. And that correlates to an increase in the local field potential amplitude at a given frequency that you're looking at. So synchrony is sensitive to signaling. Here you can see that the changes in synchrony can be modulated by different mechanisms across the network, such as changes in neurotransmitter levels. And we've talked about dopamine. So at the bottom, you can see that there is dopamine depletion that's moving to the right. The top trace is D2. And the bottom one is D1. So going back to the dopamine that we discussed in the cortical-basal ganglion thalamocortical loop, you can see the effects of the decreasing dopamine on a simulated model of the striatal neuromicrocircuit. So you can see in the upper raster that the activity of the neurons participating in the D2 network are increasing and becoming more synchronized as the dopamine gets depleted. And in the lower one, which is the D1 network, you see that that synchrony is falling apart. It's decreasing. And this, this decrease in the level of dopamine regulation is correlated, can be correlated, or the increase can be correlated with the function of the striatal network, so that in the bottom one you're almost at a state of randomness, and in the top one it's like a pathological synchronization. So this sort of aberrant oscillations can be seen in hypersynchrony or hyposynchrony within specific frequency bands as oscillation phenotypes that are correlated with various disorders. And there are two examples here. There's Parkinson's and autism. In figure A, you're looking at a depth profile of the spectral power relative to the subthalamic nucleus, or STN, dorsal border. There's a microelectrode recording. There's a mapping that's going on during a microelectrode recording of the STN here during what's called a DBS, or deep brain stimulation procedure, and that reveals a frequency map with a strong or hyper-synchronized beta oscillations, and you can see that they're beta because of this dark red area between at about 25 hertz. And in figure B, you can see there's a, these are autistic EEGs for autistic patients, patients on the ASD spectrum, autistic spectrum, that's at the bottom, and this is at the top are the controls for figure B. And here, this is, you can see the topography distribution for the gamma band spectral power during the perception of a moony face, which you see on the left underneath the letter B. And you can see that the gamma band signal is expressed as a hyposynchrony in the lower trace for the patients who have autism versus the controls at the top. Yeah? And they show a much lower gamma power as compared to the control group. Now, you can treat these different disorders by various means. There's pharmacological methods. Unfortunately, many of the drugs have intolerable side effects or lose their efficacy over time. There's behavioral therapy, which can be very effective in the case of Tourette's. Unfortunately, there are not still very many properly trained therapists in CBIT, which is very effective for Tourette's. And in cases where patients become medically refractory or treatment refractory, we can have surgery. And this is what happened in the case of Tyler, which we saw in the video earlier, where surgery was the option. Now, one type of surgery that has become quite popular and very effective and is reversible is deep brain stimulation. And this is a relatively new surgery. It's about 30 years old. And in deep brain stimulation, you have an invasive surgical procedure which targets specific areas of the brain. And those areas, when electrically stimulated, will provide a symptomological relief for the given disorder. It is invasive, it is disorder specific, and there are deep targets for this. And we have what's called an implanted pacemaker with lead wires that have electrodes on them. So if you look to the far right, you'll see these two lead wires, and there are these small silver dots on them, and those are the electrodes. I'll show you a close-up of those in a minute. Those are, if you follow the lead wires around, those are connected to extension wires, and that gets connected, the extension wires get connected to the implantable pulse generator. Impulses are then sent to the target, and that should perturb the network, moving the patient into a better functional state. Now, this is that close-up that I promised you of the lead electrodes. And what you should see here are these are two different standard electrodes that we use quite often. And what you should notice here are the actual electrodes of what we call the lead electrode. There's I know the terminology can be a little confusing. And these cylindrical silver points or pieces that you see are the actual electrodes that provide the electrical stimulation to the brain target. And they can come in different spacings, as you can see also with the left one compared to the right one. So there are two different, well, let me go back. So I'm going to show you a video that explains to you visually. Unfortunately, I can't speak while the video is on. This arrangement that we just discussed, where there is a lead electrode that is implanted into a deep target that's specific for the disorder, and how that gets connected to an extension wire. That extension wire then gets planted under the scalp, goes behind the ear, under the skin, down the neck, and is connected to the implantable pulse generator, which is implanted subclavicularly. So can I please have the video which will show what this looks like? Video, please. Thank you very much. So what you could see there is the continuous stimulation that goes from the battery and the implantable pulse generator up through the wires into the deep brain target. Now, that can, when that happens, where the wires are connected to both sides and stimulate both sides of the brain with one IPG or implantable pulse generator, that is a bilateral system. And when there's one for either hemisphere, that is called a unilateral system. I want you to remember that because that's going to become relevant in just a second. Now, the goal of DBS is to rebalance the coordination matrix in the neural circuits. So it's neuromodulatory. There's a direct alteration of the neural activity. And this can be quite effective. Going back to our figure where we saw the hypersynchronized beta oscillations, if you look at panel B, these are the Parkinson's patients again. And here you can see in B that the hypersynchronized oscillations in the subthalamic nucleus have a very high power in the, it's not going to show up here, sorry, in the LFP. So if you remember earlier where we had our red arrow with the raster plot, where as you went further down in time, you had those really good prolonged phase relations, that you got an increase in synchrony, and that increase in synchrony and mutual interaction caused a decrease in information coding capacity. But remember, that caused an increase in the local field potential amplitude at that frequency, and that's what you're seeing here in B. Now, with continuous stimulation, if you look over at panel C, what happens is that continuous DBS drops tremendously the power of that LFP, and that happens because you're now reestablishing normal phase relations, presumably, where mutual information is at a proper balance, and then the information coding capacity, we imagine, goes up, and this is why we see an improvement in the symptomatology. But what about Tourette's? So in the case of Parkinson's, we found that the dynamic coordination that was expressed pathologically in the correlated activity of the neural network was representative of the dysfunction and was corrected by altering the dynamic phase structure of those participating neurons, as I just explained. So in other words, in Parkinson's, as well as in many other disorders, it's demonstrated that aberrant oscillations are correlated with symptomatology. Now, this might not be the case in all disorders, and certainly has not been shown in Tourette's. So while we do have some insights into pathophysiology of Tourette's, we still haven't gotten a real understanding of tic etiology or tic genesis. So we want to know if oscillations play some role, since they seem to be significant for other disorders, for example, the one I showed you in Parkinson's or what we saw earlier in autism. We'd like to know if Tourette's could be a disorder of synchrony. There are theories that maybe tic genesis could be the result of hypersynchronized oscillations, because we've seen this in other disorders, but we don't even know if Tourette's really is a disorder of synchrony. So we set out to answer some of these questions and to see what the effects of to see the role of oscillations in the pathophysiology of Tourette's, which is in the far right panel, going to the left, to see what the chronic effects were or are of deep brain stimulation on the network, and also to see if there are any short-term effects that are also indicative of the chronic effects. And to get those answers, we needed to be able to record chronically from implanted DBS patients. And what we thought was that thalamic DBS could maybe correct the dysfunction in the signal transmission. Now, let's see if I can find the slide I want. There we go. To date, no one has done chronic recordings in, no one had done chronic recordings in Tourette syndrome, and because there wasn't a technology available. So NeuroPace had developed a device which could record as well as stimulate, and that device is what I'm showing you here. The NeuroPace DBS stimulator is capable of responsive stimulation and recording LFPs or local field potentials post-operatively. So we could get chronic electrophysiological recordings during the entire time that it was implanted. The local field potentials could be transmitted wirelessly from the NeuroPace implant, which contains a processor that has a memory buffer so that we could hold the recorded data, and that data would be transmitted, was transmitted via a telemetry wand that was connected to a computer. So this is, let's see if I can go to the next slide. This is what that looks like. In the case of the NeuroPace device, you'll notice that unlike the other DBS devices, which I showed you an example, this one gets implanted in the cranium. And also, as we mentioned, has various capabilities that other devices did not have at that time. And actually, I think there's still no commercially available device that does allow for chronic recordings with DBS. Now, let's see, I think I have to go back here to this slide. Yeah. So, we use this device, and based on multiple factors, not the least of which is the patient's symptoms, there are different areas or targets, as we discussed a little bit earlier, in the brain that we could stimulate. So it's really important to be able to identify, if we could, the proper target, if we could identify the brain circuit that's malfunctioning, or where we could best affect that malfunction in the circuit, then we could maybe modulate or manipulate that area and then move the patient into his or her best functional state. So finding the most efficacious target is paramount. And actually, target selection is one of the most debated issues in deep brain stimulation today. Which deep brain structure or structures would yield the best possible outcome? And in GTS, there are three major targets for consideration. There's the thalamus, which was the first target that was used in DBS. There's the globus pallidus, the GP, and also the nucleus accumbens. And the GP is often preferred for the motor relief of GTS symptoms and the anterior limb of the internal capsule / nucleus accumbens, or what's called the ventral capsule, ventral striatum, to relieve some of the limbic symptoms of the disorder. So what we did, let's see if I can move this forward again, sorry. Having some slide issues here, technical difficulties. What we did in our study was to take 5 subjects that were treatment refractory, and we used the NeuroPace device, and we performed the chronic recordings in the central median nucleus of the thalamus. We picked that as the target, and we looked at the local field potentials. Now, the clinical metric that we used for the symptomatology in order to be able to correlate behavioral manifestation of the disorder with the underlying neurophysiology, or the as represented by the LFPs, was what's called the Yale Global Tic Severity Scale, which is the YGTSS. So that was our clinical metric. And this is one page of it, so you have an idea of what that looks like. Excuse me. And here is a CTMR, so you can have an idea of how we did the target localization, and that it was verified by CTMR, in fact. And just to remind you one more time of the bilateral versus the unilateral stimulator, and because we actually ended up using both in our patients. And the electric configuration that we had for that, so using the chronic recordings, we tried to look, using the chronic recordings, we tried to look at how the impairment was improved, and we correlated that with the underlying neurophysiology in the network, as I had mentioned. And the way that we did that was by looking at the spectral power and the local field potentials. And the way that we did that was by looking at the activity across contact pairs over time. So if you look, in the case where we had a bilateral stimulator, channel 1 was derived between electrodes 1 and 2, contact or electrodes 1 and 2. Channel 2 was for electrodes 3 and 4. And then in the other hemisphere, channel 1 and 2, electrode 1 and 2 were channel 3, and electrode 3 and 4 were channel 4. Now, in the case of the unilateral stimulator, which is one device per one hemisphere, electrodes 1 and 2 comprise channel 1, electrodes 2 and 3 comprise channel 2, electrodes 3 and 4 comprise channel 3, and then electrodes 1 to 4 comprise channel 4. And here you can see that we have the largest sampling of the neuronal population, or the thalamic network. And what we ended up finding, first let me say, the structure and the coordination of the neuronal activity, right? This is what we've already discussed, and you saw that when I showed you the raster of the 10 hertz frequency and the LFP. Electrical stimulation alters this structure, and we can explore the theories, for example, hypersynchronization in GTS, about the role of oscillations in Tourette's, and how that can be corrected after DBS therapy. And the way that we do that is by looking at those LFPs, which is what you see on the right side panel of this. So what we found is that there's a clinical benefit that was correlated with an increase in the gamma band power. So this actually implies that there was a hyposynchrony, not a hypersynchrony, which means that the coordination matrix of the neurons was too loosely connected. Instead of those really good phase relations being sustained and increasing over time, we would have actually the opposite, where those phase relations are quite poor. And I'm going to show you some Welch's plots here. In this case, we have a patient which has a very high YGTSS of 97. 100 is the highest. It means it's the worst. And in this patient, we can see that there's channel 1, 2, 3, and 4 in a unilateral arrangement. So it's one hemisphere, which is the right hemisphere. And if you look, you can see that on none of these channels do we see a really, there's a little bit of alpha here, of course, but we don't see any very prominent peaks here. And this is in month 3. Now, in the next month, which was month I'm sorry, 2 months later in month 5, the YGTSS score drops to 70, which is a tremendous drop. And here you can see that there's a huge rise in the gamma band power of this patient. And in this, I just want you to take a look at the y-axis here, going from 0 to 20. The next slide is the same. I just changed the axis so you can get a real feel for how much the gamma power had increased. And in particular, I want to draw your attention to channel 4, where you can see a tremendous increase in the gamma band power. And this was where we had the highest sampling, the largest sampling of the neural population of the CN thalamus. So here we see an increase in gamma band power, which correlates with a decrease in the YGTSS score. So in another patient where we did not have a very good response to the therapy, at least initially, what we see is, again, this unilateral arrangement. There's channel 1, 2, 3, and 4, as we saw before. The YGTSS score is high, it's 82. Again, this is month 3, and we don't see much going on. In the next month, which is month 4, we also don't see a tremendous change. I'll go back and you can see there's from YGTSS of 82 go to YGTSS of 80. There's not a big change in the YGTSS score, and there's also not a big change in the underlying neurophysiology. We don't see any gamma coming up. The following month, again, YGTSS of only 78, not much of a change, and we don't have any gamma, prominent gamma peaks here. So we don't have a increase in gamma when we have a low clinical benefit. Here we have another patient, a third patient now. This patient has a YGTSS score of 73. And this is also month 3. What I want you to observe here, though, is that this is a bilateral implant. So the top 2 Welchers are the right hemisphere, the bottom 2 are the left hemisphere. Remember, channel 1 is from contacts 1 and 2, channel 2 is from contacts 3 and 4. And then in the left hemisphere, similarly, channel 3 is electrodes 1 and 2, channel 4 is electrodes 3 and 4. And you see that there is, again, not any prominent activity, a little something in the alpha, but nothing in the gamma. In the following month, there is a change of 1 on the YGTSS score from 73 to 72. And then in month 5, we see this big change in gamma from 72 to 56. I'm sorry, in YGTSS from 72 to 56. And you can see that, in fact, now you do have a change in gamma again. And in particular in the left hemisphere, where you have these very strong gamma peaks, in particularly in channel 3. And I need to be able to go back from these slides. Sorry. I'm having some, I don't know how to get these slides to go backwards. Sorry, there's some problem here with the, Now this is the following month, month 6, where the YGTSS score goes back up, and here we can see that the gamma power goes away. So gamma had shown itself when the YGTSS score had dropped precipitously. So here is a waterfall showing you the different, the pre-DBS and the post-DBS month 6 in the right panel. You can see all 5 patients. The middle 3 are the good responders, and these are after 6 months of DBS, chronic DBS therapy, except for TS2, which is the one I just showed you, which at month 5 peaked and then dropped down. So you can see that the good responders are showing a tremendous increase in gamma power, and which was not seen at all in their pre-DBS, and which we do not see in the non-responders. Now, looking at the short-term stimulation, we also notice that short-term stimulation produces increase in gamma band power. And here, what I want you to notice is the left and right hemisphere. And we took 1 minute of resting state baseline. Then, this is a recording, of course. Then we took 30 seconds of stimulation, DBS stimulation, and then another 1 minute of baseline. And that's what you see in the top, middle, and bottom panels. This is of a responder, and one of our best responders, actually, and this is month 3. And we have the left and right hemisphere. That's what you see on the left and the right. And you can see here that you have some gamma in the resting state baseline of our responder. When there's stimulation in the middle panel, there's a tremendous increase in gamma on all 4 channels, which are in the different colors. And then at the second baseline post-stim, you see that there is now a residual and increased gamma. In month 6 of that same patient, you see that the baseline gamma is a little bit higher, that there's again a strong response to the 30-second DBS stim, and then again there's this residual gamma. So what we have is short-term stimulation that mimics, as it were, what we see in the chronic, which is an increase in gamma power for those patients who are responders. When we looked at the theta band activity, we didn't see a direct correlation with clinical benefit. But what we did see is that there was, let me see, do I have yeah, here we go. So when we look at the theta gamma here, and we compare it to the YGTSS scores, we see that the gamma has a direct correlation with the change in YGTSS, but that the theta is not consistently changing in one direction or the other. I'll tell you though, when we did look at the cross-frequency correlations, there were direct correlations in theta gamma cross-frequency power to the YGTSS, just as we had seen in the gamma itself. So what we can, what our results and conclusions are now, what we can deduce from this is that DBS-mediated enhancement of gamma synchronization is associated with the symptom relief in Gilles de la Tourette syndrome. We also found that there is no direct clinical correlation between thalamic theta band oscillations and the symptomatology. The underlying pathophysiology of GTS is functionally expressed as the hyposynchronization in the cortical-basal ganglia thalamocortical network. And we found that the therapeutic deep brain stimulation could in fact correct the dysfunction in the signal transmission at the level of the thalamus, and that this was altering the strength of the neural coordination matrix, as we discussed. And that change in coordination was marked by gamma. There are transient changes in the gamma that might guide responsive stimulation intraoperatively to improve targeting DBS of GTS, deep brain stimulation of Gilles de la Tourette syndrome. This is something that we look forward to testing intraoperatively and for closed loop paradigms in the future. This could be helpful also postoperatively by giving a objective measure for stimulation parameter, for the stimulation parameters. And what we know is that modulation of the gamma band activity by deep brain stimulation of the central main nucleus of the thalamus is a key factor in mitigating the pathophysiology associated with GTS. So with that, I would like to end my talk and thank you all for attending. I'd also like to give thanks to the team in Florida who did the work that I just described. Nicholas Mailing, who's now in Ohio, Eric Atkinson, Justin Sanchez, who's at DARPA, Mike Oken, and Kelly Foote, and some people from NeuroPace and the admins in Florida. So if there are any questions?
Thank you for that presentation, Dr. Hashemiyoon. We want to get right to your questions and input, so here's a reminder on how to let us know what you have to say. Questions can be submitted via the Q&A button at the lower left. We will try to get to all of you, but if not, we will be sure to follow up after the broadcast. And now we'll get to our first question. how can you or did you verify that the positive effects you see are due to the stimulation rather than the surgery itself?
Okay, so that's a very good question. I imagine that what the person is asking about is something that's called the microlesional effect. So this is an effect in which the patient will experience the amelioration of symptoms just by virtue of the surgery alone. And this can last up to a couple of months or so. Typically, if it does occur, it happens for a much, much shorter period of time, 1 or 2 weeks. The best way to show that, let me see if I can find the slide for that. The best way to show that that was not the case is here with patient 2. So in this case, when we were looking at the month before, we saw that there was a YGTSS score of 72 and there were no prominent peaks. And then in the following month, when the YGTSS dropped, we saw that there was this increase in gamma. But then when we went to the following month after that, the YGTSS went up again, and then you see that the gamma is gone. And this cannot be the microlesional effect, because that would consistently be showing something, or it wouldn't be a spike and then a drop again that would correlate with the YGTSS like this. So that's the best evidence for this being a real effect versus just the microlesional effect. And also these are now months out, so this is month 5 that we see that effect. So that wouldn't be the microlesional effect. Same with the other patients, actually, the patient that I showed you, that was in month
You've shown very nice work shedding light on the neurophysiological aspect of tics, but it's all from the thalamus. What about the cortex?
Yes, this is true. We were recording from the thalamic network. One of the things that is relevant is to look at the larger network. And in fact, that's work that we're doing here at the University of Cologne in the Department of Stereotaxy. So in this little animation, I have a good slide for this to show you the work that we're doing now. This is the DBS electrode, which will go into the deep target and will allow intracranial or depth recordings. So here you can see that, I'm sorry, I think I got cut off. So here you can see the depth recording, and with that we combine with, so we can get the subcortical recordings, and with that we combine by adding EEG, which will give us recordings from the cortex. And if we put those together, then we can get what is the cortical-subcortical network. And an example of what that looks like with high-density electrodes, because we're using 256 channels using the EGI machine. Here you can see all the different channels. This is a raw recording until you get to the very end. At the bottom on the over there, you can see those are the depth recordings that are also together with the EEG. And this will allow us to look at the large-scale network and what is happening with the dynamic changes in that network, and how the communication occurs between the two areas. I just want to show you a slide also of what it looks like when we externalize the electrode. The way that we're able to record from the intracranial electrode is by externalizing that extension cord that I was talking to you guys about earlier. And now this is an example of the Versailles system from Boston Scientific. So this electrode is now coming out, and you can see there are 8 electrode contacts. And that reflects the 8 electrode contacts that are inside the deep target. And together with the EEG, we can as I said, get more information on the functional connections and how they change with the DBS therapy. Next question, please.
Great, thank you so much for that answer. Our next question is, I never knew you could do chronic recordings using DBS. What are some of the other advances in technology that are relevant for the treatment or study of the human brain?
Thank you. There are quite a few, this is a very exciting time in DBS. There are quite a few new innovations that are coming out. The most important of those is what's called the directional lead or steered stimulation. And in that case, so what you saw when I just showed you the last slide was 8 electrodes on a lead. So having, more refined and more areas that you can record from and stimulate will be extremely relevant. So here, is an example from Abbott, or what was St. Jude, of different electrode configurations for the directional lead. They're called directional leads because remember when I showed you, let me see if I can bring up that slide again, here where you have the nice cylindrical contact points. In the case of directional leads, instead of having just cylindrical contact points, what you have are segmented electrodes. So instead of a full circle, you've got 3 segments that go around instead. And that's what you see here in the middle picture. So the 2 center electrodes are actually segmented into 3 parts, and you can activate either of those segments or all of them. And both Abbott and Boston Scientific have these systems right now available, which is wonderful. And with Boston Scientific, we also have a constant current. I think I have a picture of that one too. Here's that system right here, and you can see the 2 center electrodes are segmented into 3 pieces. And the piece that you see at the top is for orientation, so that you can know which direction the electrode is, and you can know which segment you are activating, so that if you are doing, let's say, a Parkinson's surgery, it would be, you could get closer to the internal capsule, and you could steer away by activating the segment that's on this side where the STN is, the subthalamic nucleus, and not activating the segment of the electrode that's close up against the internal capsule, therefore not getting those side effects, those capsular effects. So this sort of thing is extremely useful. And then if you can also record from them, you can record from a more refined area of the target or targets in which you're implanted. And so you can get a better feel for what the interactions are in the larger scale network that I was just discussing with you from the last question. So I think that these are really relevant for the kinds of things that are coming up. Also, things like smartphone applications. I have this St. Jude, or what is now Abbott, Infinity system. This is already available. One of the things is being able to have smaller and smaller IPGs, or implantable pulse generators, and also having access by smartphone, so the patients are able to tweak their stimulation settings themselves a little bit. And instead of pulling out this large device that could, invite questions, what they can do with a smartphone application or connected technology is to be able to quietly and without drawing attention to themselves access their device and make corrections as they see fit. And I think that's really relevant. And also through the connected technologies, I think that's a very welcome resource for patients, especially that will have a hard time making it to the physician's office. So information can be sent over to the physician from, let's say, an iPad or a tablet, and that will allow the physician to optimize the settings for the patient when they're sitting in their office, because that information is sent over. So I think those things are really practically relevant and now available, and moving forward will be, more and more accessible through the different companies. The device that we use to be able to do chronic recordings, which are really important, because we discussed that target localization or target selection is one of the most important things that we have to focus on right now, so that we can be able to improve the therapeutic window where the patient gets the optimal effect and with minimal side effects. And I think that having recording devices will help people like myself who are trying to understand the underlying pathophysiology of these disorders, which we don't really know at all. And the better that we understand them, the more we can improve the surgical procedure to improve this therapeutic window. So things like closed loop stimulation, being able to understand, for example, in the case of Tourette's, the gamma oscillations are really relevant for tic genesis, and being able to intraoperatively apprise the neurosurgeon that yes, you are in the best possible target right now, so that when the patient is closed up and has a stimulator, everything internalized and implanted, we know that we have the best chance of improving the symptoms and the disorder for the patient. So Medtronic had the PC plus S device, which was CE marked and FDA approved, but is not commercially available. I think they're coming out with their next generation device, which will also, I think, include closed loop stimulation. So these sorts of things moving forward, I think, will be really relevant for the future of DBS. Do we have any more questions?
Great, thank you so much for that answer. Looks like we have time for one more question. And actually, this is a two-part question. The first part is, did you use other manufacturer electrodes as comparison? And the second part is, why did channel 1 seem most effective in 4-channel stimulations?
So I guess, so the first part of the question is, did I use another manufacturer's electrode? So that's not possible. So with the NeuroPace device, that is quite different from the other devices that are available on the market now. It's a responsive neurostimulator, that's the RNS system, and it, like the other devices that I showed you, the IPG, they plex with their own electrodes. So you can't put, for example, a Boston electrode with a Medtronic IPG. So the only device that you could record from at that time was the NeuroPace device, and you could only use their own electrodes to be able to record and stimulate. So that's the answer to that. And then the second part of the question was, I think that there was a stimulation on channel 1 and recording on channel 4 or something like this. So let me clarify that when we stimulate, we were stimulating across the different channels, and we were also then recording from those channels. So the stimulation wasn't specific to channel 1 and then the recording from channel 4. We actually recorded from all the channels, and then that's what I showed you in the Welch's plot, is what we ended up seeing from the bipolar derivation of the electrode recordings. So I just brought your attention to channel 4 because that was the largest sampling of the network, and because we also saw the greatest response there, it implies that this is in fact a larger scale network phenomenon that's going on. So I think that answers that question, I hope. Do we have anything else, or are we done?
Thank you so much, Dr. Hashemiyoon. Do you have any final remarks?
me to join in this wonderful event. And I'd like to thank the viewers for coming to watch the talk. And I hope that this was helpful to people who had any questions about the underlying pathophysiology of Tourette syndrome, of the functioning of the basal ganglia, and also the efficacy of deep brain stimulation, which I think is a very powerful tool for being able to not only help patients who are medically refractory, but also to learn from the procedure to improve as we move forward for each patient then coming in. I think it's important to be able to really maximize or optimize the tools that are available to us for recording from the human brain so that we can improve our understanding of the human brain dynamics.
Thank you once again, Dr. Hashemiyoon. I would also like to thank LabRoots for making today's educational webcast possible. Today's webcast will be available for on-demand viewing on our website through June 15th, 2017. We will let you know when it's been posted, and we hope you pass that information on to any colleagues who couldn't take part in today's broadcast. See you next time. Goodbye.